and answer any questions that you guys have. Can y'all see my screen okay? Thanks, Scott. Okay. So today I wanted to go over pulmonary hypertension with you guys. Some of you have had the pleasure of taking care of a baby up in the PICU right now who's got pretty severe pulmonary hypertension. But I wanted to be sure that you guys had a strong background understanding of what that is and what causes it and how we can treat it. So, here we go. Sorry, y'all. My slides do not want to forward. There we go. So today we'll talk about pulmonary vasculature, the definition of pulmonary hypertension, what's happening physiologically in patients with pulmonary hypertension, how they present, what their risk factors are, what a workup for pH looks like, and then common treatments and things to know both as an outpatient and if you are hospital-based. So it's important to understand what normal is before we start talking about abnormal issues within the pulmonary vasculature. So if you look at this picture here, it shows you a pictogram of the pulmonary circulation versus the systemic circulation. And if you look at the top, you see the mean pressure in the systemic circulation would average 100 with a pressure of 120/80. Typically in the pulmonary pressures, you would see 25/8, which is about 15 mean average. So this side here, this pulmonary side, is a very low pressure system. It's a low flow system and a high capacity system. And what does that mean by high capacity? It means that it can accommodate a significant increase in blood flow. So whenever you are exercising and you are requiring more cardiac output, you can actually pump more blood into your lungs so that you can oxygenate and support that activity. So even with that ability, typically this pulmonary pressure system is going to be about 1/10 of the systemic blood pressure. So what then is pulmonary hypertension? And that is essentially increased pressure within those pulmonary vessels. It may mean that the vessels do not have the ability to accommodate that increase in blood flow. It also may mean that at rest, the pressure is high and gets even higher when you stress the system. So here on the left, you can see a cross section of a healthy pulmonary vessel. So a thin walled vessel that's open in the middle, a cross section of a normal right and left ventricle where you have a thin walled, slightly bigger right ventricle, a thicker walled left ventricle. When you have the development of pulmonary hypertension, a lot of times you will have vasoconstriction of the pulmonary vessels, as well as remodeling within the walls, where the walls themselves start to become thicker. And this increases that pulmonary vascular resistance. And over time, that right-sided heart does not have the musculature meant to pump against these high pressures. So eventually you're going to compensate and you're going to get thickened walls of the right ventricle, and it's going to start to hypertrophy. And over time, that can actually decompensate, where you then have the right ventricle essentially giving up, thinning out, and becoming much less productive in its function. So the definition of pulmonary hypertension is a mean pulmonary artery pressure greater than 20. These pressures can be a little bit difficult to ascertain, especially without a cath in a patient with a congenital heart disease. And in pediatrics, the best way to calculate this is pulmonary vascular resistance index to body surface area. Not every center routinely reports this, but in the literature, this is the gold standard. So you also want to look at what their pulmonary pressures are estimated to be based off of their blood pressure at that time. And so we look at these young kids where we only have echocardiogram readings, we don't have cardiac caths, and we can look at their estimated pulmonary pressures as related to their systemic pressures. So, and then if you were to get numbers by cath, you would typically see 8 to 20 millimeters of mercury of pressure in a normal pulmonary vessel. And then this PVRI number is measured in Woods units. And you can get this from a cath. And so greater than 3 Woods units would be considered elevated. So this is just how pulmonary hypertension can develop over time, where you have this chronic increase in pressures, and you have at first a pretty normal cardiac output. Then you can start to see a slight decrease as the pressures get higher and higher, and then eventually you can move into right ventricular dysfunction and failure. And when that happens, you end up have bowing of the interventricular septum into the left ventricle, which can actually compress that left ventricle and decrease your cardiac output, just because there's no space there for the blood. So sometimes you'll see this happen in babies in the NICU where they're doing well and they're weaning their support, and you're like, oh, they're doing great. And then something happens, they might go and get their G-tube, they might get sick, and then all of a sudden, they are not doing okay. And that's because you are starting to get into this window of disease. And it can be surprising for a lot of people because it looks like the baby's on track to go home, and then all of a sudden they no longer can accommodate or deal with their pulmonary pressures anymore. So pulmonary hypertension in pediatrics has really kind of come to the forefront in the last decade and a half. There is a specific group looking at pulmonary hypertension internationally. There's also a separate group looking at pediatric pulmonary hypertension. So the most recent guidelines came out of a meeting in 2018 in France. This is how pediatric pulmonary hypertension is currently classified, and you may see in some of my notes that I will give specific numbers of what their World Health Organization classification is and their Panama classification, and that's what this comes from. So there's pulmonary arterial hypertension, which is mostly idiopathic, maybe really related to genetics. There's pulmonary hypertension related to left heart disease, lung disease, and pulmonary artery obstruction. So a lot of times we'll see this diagnosis here under group 1, persistent pulmonary hypertension of the newborn. And so there are a lot of different things that can lead to this. Down syndrome is an increased risk for pulmonary hypertension, which is a comorbidity in our patient up in the PICU, meconium aspiration, and so forth. So other issues that can lead to pulmonary hypertension are things that are actually post-capillary. So the draining veins can be problematic and give the impression of pulmonary hypertension when actually the veins are what is contributing to the higher pressures. A lot of times what you'll see is that if you have pulmonary vein stenosis or some other post-capillary issue, that as soon as you add vasodilators, you're going to have florid pulmonary edema. And so that should always make you think, well, maybe there's something with the pulmonary veins. Maybe it's not a pulmonary artery issue. And then what we see most commonly with kids who are going home on medications is pulmonary hypertension related to developmental lung disorders, which is essentially our chronic lung disease babies. We also see it in kids who have congenital diaphragmatic hernia, Down syndrome, as I said, other developmental issues such as surfactant deficiency and so forth. So this is that other group of classifications I mentioned, the Panama classification. You don't need to know all of these nitty-gritty details. I just wanted you to be aware that there are some different classification schemas. So pulmonary hypertension in kids, obviously, you guys know, pediatric medicine is not the same as adult medicine. So most of what you guys have seen, because it's the most common, is pulmonary hypertension related to chronic lung disease of prematurity. However, kids do get idiopathic pulmonary hypertension where they've been healthy and then all of a sudden they start having symptoms, and this is the etiology. So typically kids or teenagers that are going to present with this will have syncope. So not saying you need to think every kid who has syncope has pulmonary hypertension, but that is a common presentation in kids with PH. They tend to have longer preservation of their cardiac output. They sometimes you'll see it as a long-term impact from congenital heart disease. They don't have as many connective tissue disease issues like the adults do. And they don't tend to have as many thrombi. Adults with PH tend to get a lot of clots. So in kids, there's a lot of different factors that can go into the development of pulmonary hypertension. So if you look at, especially preemie babies, you can have issues with lung development, chromosomal or genetic issues, insults on the lungs as they're developing and growing, as well as other conditions. And it's important to, you do not need to memorize this, but this is how the lungs develop in the different stages of lung development over fetal growth. And so when babies are born prematurely, their development somewhat arrests in this stage and then slowly starts to improve. And so when you've got a baby who is born at 26 weeks, you don't have fully developed alveoli and the matching vessels that should be right up next to the alveoli for gas exchange. And so now you've got an issue. Those vessels can't do what they need to do. And so over time, they actually are going to impact how the lungs function and can develop increased pressure over time. So the vessels are there, but they're not always lined up appropriately in the prenatal babies just because they're born too soon. And so if you can see on this chart talking about the alveolarization, that's one of the last parts of the lungs to develop is the alveoli, where gas exchange occurs. And so if you don't have that connection, the body is working a lot harder to try to develop that. There's going to be a lot less capacity of the lungs to deal with increased blood flow. It's not necessarily you're not going to have better gas exchange with increased blood flow. And so over time, those vessels actually start to thicken and get a little bit scarred. And then you start seeing increased pressures on echoes. This is a little bit of a complex point of physiology. Don't feel like you need to fully understand this. It's not going to impact your ability to take care of these kids. So remember at birth, so prenatally, pulmonary vessels are vasoconstricted and there's not a lot of blood going through them. And there's a lot of smooth muscle in those vessels. At birth, you've got mechanical distension of the vessels when the lungs inflate. Your PaO2 goes up. Oxygen is a vasodilator, so you start having dilation of the pulmonary vessels. You have the closure of the ductus and the umbilical vessels, and then you have all of these other chemicals that are released that help transition from prenatal to postnatal pulmonary circulation. So we'll back up just a little bit and talk about how common pulmonary hypertension is. So it's not super common, but it's not so rare that you're never going to see it. So you can see here, there's some slight differences, but not a lot between the prevalence and incidence in Europe and the US. Like I said, it's been the last decade to decade and a half that we've really been trying to increase our knowledge about the difference of in pediatrics with pulmonary hypertension. There are a lot more patient registries that are developing and growing. And we'll talk a little bit about some certified centers around the country, which is a newer development, and we'll talk about that. So there is definitely a genetic component in some patients with pediatric pulmonary hypertension. So about a fifth of them have an underlying genetic cause for their PH. The most common mutation is BMPR2. This is not something that we always go down the rabbit hole for with these preemie babies, because most often it's their chronic lung disease that's driving their pulmonary hypertension. However, if you have a patient that's not responding to medications the way you think, or their overall picture seems a little abnormal, you could consider whether there is something else driving their pulmonary hypertension. Particularly, you can see some thyroid issues associated with pulmonary hypertension. So if you have particularly an older kid, but you could think about this too in a baby, what would your differential diagnosis look like in a kid who's coming in maybe with some shortness of breath, maybe with some syncope, maybe with some fatigue? And so you think about all the different potential etiologies. If you're thinking pulmonary hypertension, you need to know what the risk factors are. So do they have a family history of it? Do they have a history of congenital heart disease? Were they a preemie? Any knowledge of connective tissue disease, anemia, long-standing obstructive sleep apnea is been shown to be associated with pulmonary hypertension. So if you're seeing somebody and you're concerned about pH, you want to know prenatally any drug exposures, any known medical issues, any medications that they're taking. There are certain meds that can increase pulmonary pressures, family history, and then do they themselves have any drug use or other potential exposures. Different symptoms that they may report, like we said before. Hold on one second. Sorry, guys. Okay, so you may see syncope, fatigue, poor growth, difficulty with exercise. Syncope with exercise also should kind of pique your interest in pulmonary hypertension. Some kids may develop headaches, dyspnea, hemoptysis. These are a lot of non-specific symptoms, but if you're seeing kind of a constellation of these and multiple of them and you don't really have another diagnosis, at least have pulmonary hypertension on your differential. Some of these kids will have some tachycardia. Some may develop telangiectasia. Sorry guys, it's Monday. On cardiac exam, one of the big things that you may hear is a prominent P2. They may develop JVD. Some of them develop hepatosplenomegaly, clubbing, cyanosis. All of those things can be seen obviously with other diagnoses, but also with pulmonary hypertension. So typically you would get baseline labs. A BNP is an important part of that initial workup. Your first line for imaging would be a chest x-ray. And the things that you can see on a chest x-ray with pulmonary hypertension is highlighted here. So on the right, increased central vascular markings, absence of peripheral vascular markings, which is called distal pruning. You may also see an enlarged pulmonary artery, which will kind of show you that bump there. And then if you end up getting a CT scan, it's also useful to compare the size of the pulmonary artery to the aorta on the CT. So typically, we are going to diagnose pulmonary hypertension with echocardiograms. Gold standard is cardiac cath, but one, not all patients are stable enough for cardiac cath, and as you know, we can't actually do them here. So a lot of times we're following and diagnosing pulmonary hypertension with echoes. So here you see a normal cross-section of the heart. What you will sometimes see on a pulmonary patient with pulmonary hypertension's echo is right ventricular enlargement. The septum may be flat or bowing into the left. It should typically round into the right ventricle. So if it's flat, that means that the pressures on the right are higher than normal. What's really helpful is being able to get a tricuspid regurgitant jet, because this you can actually estimate pulmonary artery pressures. The problem is that if you have any problem with your pulmonary valve, this is not going to be pulmonary or tricuspid valve. This is not going to be as reliable. We also look at the position of the intraventricular septum. Sometimes if there is a shunt, the velocity of that shunt and the direction of that shunt can be helpful. So if you have a PDA, that should always be shunting left to right, right? Because your systemic pressure is on the left, pulmonary pressure on the right. Your blood should be moving from high to low pressure. If your pulmonary pressures are getting close to systemic or are above systemic, you should be seeing either bidirectional flow or right to left shunting. And often if you're seeing right to left shunting, you're going to see desaturations as well. So also we look at the size of the right atrium and the right ventricle, the function of the right ventricle. A lot of places have gone to calculating what's called a Tapsy score. We don't typically see those on our echoes. And then you also want to make sure there's not any left-sided heart disease or effusions. Depending on the presentation, some pulmonary hypertension patients will need to go on to CT scan with angiography. A lot of times this is looking for the underlying etiology for their pulmonary hypertension. So pulmonary veno-occlusive disease or CTEPH, those are both post-capillary issues. Interstitial lung disease can also increase your risk of pulmonary hypertension. And so looking at the pulmonary parenchyma can be helpful. The other thing you would want to do is rule out any complicating OSA that could be contributing to their pulmonary hypertension. Some patients, VQ scans and cardiac MRIs can be useful as well. For older kids, sorry, my slides aren't advancing. For older kids with pulmonary hypertension, it can be useful to follow a 6-minute walk test, which is essentially monitoring the distance that they can walk, what their heart rate is, and their oxygen saturations over that 6 minutes. And there are some standard values that you can compare to see where they fall in their functional status. Cardiopulmonary testing can be useful, spirometry with body plethysmography, DLCO. These are all things that can be used. And these are a lot in the older kids. These babies that you're seeing with pulmonary hypertension, we aren't doing this on, but I do have a couple of older kids and teenagers that we follow some of these on. So cardiac cath is going to be your gold standard for diagnosis. This typically does not occur in tiny babies and super unstable patients. This is not a risk-free procedure. But what it allows for is more direct testing of the pressures to see if they'll respond to vasodilators. So that includes turning their FiO2 up to 100% and giving inhaled nitric oxide to see if either of those things will decrease their pressures. And typically that can be helpful in deciding long-term management, but also gives you an idea of how well they may respond to other pharmaceuticals. So only 10 to 15% of patients are actually going to be considered responders in this situation. So really what's quite helpful is getting the actual pressure numbers. And this is what you may see if you're looking at a cardiac cath. So you'll see a diagram of the heart and then different pressure readings throughout the different places where they have threaded the catheter. So number 1, you can see has a pressure there and then an M equals 50. That's your mean PA pressure. Remember we said less than 20 is normal. So in this particular kid, their mean PA pressure is 50, which is elevated. The other thing that you want to look at is your pulmonary capillary wedge pressure. So that also can give you an idea about whether you're dealing with pre or post capillary disease. So then number 3 shows you that calculated PVRI in Wood's units. And remember, greater than 3 is abnormal. This kiddo has a PVR of 12.7 on Romer. If you go to the next block, it's 10.7 with 100% FiO2 and 11.1 with 100% FiO2 and 40 parts per million of nitric oxide. So this kid's not really a responder. And then number 4 shows you, again, vasodilator testing with the mean PA pressure. Let me stop really quick before we get more into the weeds and ask if there's any questions so far on what we've talked about. I can't see the chat, so, oh no, I can. No questions? Okay, let's keep going. Just checking the time. Okay. So the current published diagnostic algorithm for pulmonary hypertension is kind of complex. And again, we don't typically go through this whole algorithm for baby in the NICU who's developing pulmonary hypertension. But we would look at this for an older kid who's coming in, who's got an abnormal echo with elevated pressures, to try to figure out what the underlying etiology is. And so typically you're going to start with an echo, an EKG, chest x-ray, and then you kind of move down this algorithm based off of your results. So one important part of classifying patients with pulmonary hypertension is not only what the etiology of their disease is, but what their functional classification is. And initially there were these particular New York Heart Association functional classes, which are a little bit difficult to apply to children, especially children who aren't ambulatory and who may not be able to developmentally do all of their activities of daily living. So there is a pediatric functional class that is much more specific to different age ranges, talking about whether or not they can actually go to daycare, whether they can play without getting short of breath. Do they stop crawling? Are they not eating well? How is their weight gain? So these can be really useful in classifying younger children. So how do we treat pulmonary hypertension? So there's a lot of different ways that you can approach this disease. And that's nice because we can overlay several different mechanisms of action with these patients to try to get the effect that we need. So you can see here that there are ways that you can approach this from an inhalation standpoint. So if you look here on the right, oxygen is a vasodilator. Prostaglandin analog. So if you've taken care of that baby in the NICU, iloprost is one of those. Nitric oxide. And then there are other ways that you can affect the endothelial layers and smooth muscle layers of the vessels, including nitric oxide, but also the endothelin receptor antagonist, which is bosentan. And then there are other vasodilator and antiplatelet medications that can assist with decreasing clotting and relaxing the pulmonary vessels. And then if there is a component of inflammation, some of these medications actually address that too. So as in many diseases, our pediatric guidelines are consensus-based and pulled from the adult literature, which is evidence-based. So not 100% ideal, but better than not having any evidence-based guidelines to base this on. The treatment strategies for kids are to help them be able to do their normal childhood activities without limitations and improve survival. So kids are at risk for death from pulmonary hypertension, and so it's not without its significant risks. The only medication approved by the FDA for use in children for pulmonary hypertension is bosentan. So everything else that we use is technically off-label, but there are quite a few centers within the country that communicate and utilize other medications, particularly sildenafil as well. The only drug trials right now that are occurring are with patients with idiopathic or type 1, group 1 pulmonary hypertension. So when you're looking at treating a patient with PH, you also want to look at what their risk factors are. So I think it'd be useful to paint a clinical picture for you. And we can utilize the patient that some of you guys have followed in the PICU. This is a 26-weeker with trisomy 21. Who had some complications early in the NICU. She had she had neck. She required bowel resection with an ostomy that then got reversed. But at some point, I think at about 6 weeks of age, she had an abnormal echocardiogram with elevated pressures. And I think her pressures were about 50 or 60 at that point. So we started her on sildenafil, and over time, she continued to have kind of her echo pressures would bounce up and down. She struggled to come off of respiratory support. And then after she went home from the NICU, she went home on oxygen and sildenafil. She had a significant event where she came into the ER and her pulmonary pressures were suprasystemic at 105. So if we think of a patient like that, we can kind of walk through what her risk would be. So clinical evidence of right ventricular failure. Well, her echo showed low systolic function of her right ventricle, so she would be yes. Progression of symptoms, yes. We can't look at a 6-minute walk test. Growth, she was not growing great when I saw her in clinic 2 weeks before. Her functional class, she's really not able to participate in anything because even just coughing, she would desaturate. So I would say she has a high functional class. And by high, I mean poor function. Her BNP was 900, so it was significantly elevated. Her echocardiogram showed RV enlargement. And we don't have hemodynamics, so we didn't have a Cath. So she had a lot of features that put her on the higher risk side. So patients who are diagnosed with idiopathic or familiar or genetic pulmonary hypertension, they follow a slightly different path than these babies that we see in the NICU, that's just kind of changing gears a little bit here. But this is not something that you need to worry about knowing. Just know that pulmonary hypertension really needs to be seen quickly by a PH specialist so that they can look at what this patient needs and get it underway quickly, because you don't want to get the heart somewhere where it's starting to struggle because it can be really hard to get back from that. So typically patients with pulmonary hypertension, you want to keep their lungs functioning as well as possible, because any problems with mucus plugging, atelectasis, lower SATs, acidosis, all of that increases your pulmonary vasculature, the vessel pressures. And so maintaining their lung disease can really help keep their pulmonary pressures from elevating. So fever also increases metabolic demand and can cause their pulmonary pressures to go up. It's important to keep them as healthy as possible so they don't get sick, because anytime they get sick, you're going to have all those issues that we just talked about: fever, atelectasis, mucus plugging, and etc. So you want to avoid constipation, because vageling can actually increase the vessel tone in the lungs and cause them to clamp down those vessels. In older kids who have pulmonary hypertension, you want to be really careful that you're not putting them in a position where they need excessive cardiac output, so no competitive sports. And then you want to be careful when they're flying or at a high altitude, because the FiO2 both in a plane and at high altitudes is lower. So if you didn't know, the FiO2 typically in a plane is 18% as versus 21% at sea level. So anybody who has pulmonary hypertension, or if you have a baby who's on oxygen, just be aware that they may need a little bit more support when they're in the air, because it is not the same oxygen percentage. Okay, so treatment for these patients. Couple things to consider. You want to be sure if they need to go under any procedure, even often, tonsillectomy. You want to make sure that you've got anesthesiologists who are prepared to deal with intra-op complications. So complicated procedures should be done with CV anesthesia. Simpler ones, you need to make sure it's somebody who knows how to use INO intraoperatively and potentially even iloprost. So pregnancy can really complicate pulmonary hypertension in women and cause it to be significantly worse. So female teenagers really should be on birth control if they have pulmonary hypertension. The risk of mortality, as you can see here, is incredibly high. So a lot of times we treat with oxygen and positive pressure. Positive pressure because you maintain better lung volumes and give some extra support to the heart. Additionally, you also don't want to overinflate, because if you are hyperinflated in the lungs, that actually starts to compress your pulmonary vessels and also contributes to higher pulmonary vascular resistance. Medications that we use: diuretics, anticoagulation, typically in the older kids, There are a wide range of oral agents. Some are not appropriate in babies. So typically you'll see in the babies the sildenafil, the bosentan, and that's usually it. Older kids, you might see tadalafil, which would be an alternative to sildenafil. Ambrisentan and macitentan are alternatives to bosentan, and selexipag is a separate drug class. There are some inhaled medications, and you'll see us use iloprost typically in the ICUs. There are some IV agents, treprostinil and epoprostenol. So these medications we do have pharmacy protocols in place for. In the 2.5 years I've been here, because I helped write those protocols, we have not used it. So it's a super risky medication. There's increased risk for bleeding. It has a high risk of rebound pulmonary hypertension if it comes off. It has to have its own dedicated line. You can't flush anything through it. You can't pull back off of it. And typically it has a short half-life. And so if something happened to interrupt the infusion, you would have to have a backup line where you could immediately switch over, because you could have severe rebound pulmonary hypertension if you didn't get the infusion going again quick enough. And then some patients utilize home subcutaneous treprostinil, which, to my understanding, the last time I talked to our Credo rep, we actually don't have any kids in South Carolina on the subcutaneous version. So in adults, this is kind of the different categories that we're looking at. The endothelin receptor antagonists, your PDE5 inhibitors. We don't use riociguat. The prostacyclin pathway medications, that's the treprostinil, iloprost, selexipag. So in really extreme cases, some patients have actually gone under atrial septostomy. So actually going in and forming an ASD. And this actually allows the heart to have a pop-off, which is why sometimes having a residual PDA can be helpful, because if the pulmonary pressures are really high, then it can push and shunt blood from right to left. And that way the right ventricle is less likely to fail because it has a pop-off valve. So some patients whose pulmonary hypertension is so bad that they're looking at transplant may get an atrial septostomy to buy them some time. The other thing that's been used, and most of these have only been done in St. Louis and Houston. There's surgeons there that have done these. So the reverse Pot Shunt, which can offload the pulmonary artery. These are relatively risky procedures. That's another option to give essentially a pop-off valve. And then I've seen 1 or 2 in Houston transcatheter VSD created holes. So these are super risky, and usually for patients who are not responding to all the other interventions. Any questions so far?
This is most definitely.
I have a question.
Yeah.
The one that you said could have severe rebound pulmonary hypertension, is that something that once they improve, you just wean them off
Yeah.
slowly? Okay.
Mm-hmm. Yeah. So the problem with that medication is it's so potent, and the half-life is so short that a lot of times you have maybe 10 minutes to switch them to a different line, which is why typically you need a central line that this is the only thing that med's going through, and you need a dedicated second backup line that you could immediately stop anything that was going through it and move your medication to that line. So it's not without significant risk. So so the prognosis for these kids has improved over the last 10 to 20 years. Before we had all these medications that we were using, their 5-year survival was around 30%. Now you can see here that the survival is much improved, but still at 5 years, 50%. And it's worse in patients with idiopathic pulmonary hypertension. And if some of you remember, the teenager who we flew down to MUSC a couple months ago had pretty severe pulmonary hypertension, and we already had her on 3 meds, and we're looking at sending her to potentially get a Pot Shunt in Houston. So like I was saying, if you've got idiopathic or genetically based pulmonary hypertension, you have a worse prognosis, mostly because you can't fix that. All right. And this is a reason for lung transplant in children. So if you look at the reason for transplant separated by age, you can see that idiopathic pulmonary hypertension contributes to not an insignificant amount of the lung transplants. Pulmonary hypertension that's not idiopathic, you can see under the age of 1, these are your extreme preemie babies with horrible, horrible pulmonary hypertension and lung disease. And then still the most common in the older kids is cystic fibrosis. So this is, I mean, this is not a small number of lung transplants, because this is over the course of 17 years. So this is a lot of lung transplants. So the things that are important for you guys to know is if somebody comes into the hospital and that you know they have pulmonary hypertension, what are the things that you need to be extra thoughtful about in those kids? So first of all, you want to make sure that they aren't too dry, because that can impact their cardiac output. You want to make sure that their oxygen saturations are a little bit higher than what you would want in another kid, typically above 93%, because we know lower oxygen saturations can increase their pulmonary vascular resistance. You want to avoid acidosis, hypercarbia, hypoxemia, atelectasis, all of that, because that increases PVR. The other thing is that don't stop any of their medications or wean their oxygen from their home level unless you've talked to pulmonary or cardiology, because most likely that oxygen is part of their pulmonary medication regimen. If you have we had somebody come in when I was a resident who was on I'm pretty sure looking back was on subcutaneous pH medication. If someone comes in and they get admitted and they're on a subcutaneous medication and you're not sure what it is, don't ever stop it without getting more information. And not that I think anybody would, but it can be super risky. Even the home medication that's subcutaneous, it's similar to the one that Megan was asking me about. The half-life is longer, but still isn't super long. And so you want to be really careful to not stop that medication. So why do kids die with pulmonary hypertension? It's typically due to progressive right ventricular failure. So then they end up with decreased cardiac output. If they get a complicating illness, it can be very hard for them to come back from that. They're actually at risk for arrhythmias, especially if they're acidotic or hypoxemic. They can die suddenly from these arrhythmias. They are at risk for pulmonary emboli, massive pulmonary hemorrhage. So these kids can get really sick really fast. The other thing that can occur is a acute pulmonary hypertension crisis, particularly if they are acutely ill and they are having a lot of issues with oxygenation or ventilation. And you get into this cycle where the pulmonary vasculature starts to clamp down. And then eventually it can actually clamp down so much that you can't rescue it with any of your medications. And typically, if you're seeing a severe pH crisis like that, you're going to see desaturations and bradycardia together. So these are the current pulmonary hypertension centers within the country. So these are centers that have been recognized by the Pulmonary Hypertension Association. Currently, there are only 8 clinical centers of comprehensive care. And we have utilized both Vanderbilt here and Texas Children's here for our patients in the past when we've needed to refer. So we did create a pulmonary hypertension team here in Columbia. Dr. Rao and I see a lot of these patients and follow them up closely. So I don't know where our future lies as far as a clinical care center, but definitely trying to improve the care that our patients get here. It's a really complex disease. It is a super scary disease. Everybody should have a healthy fear of pulmonary hypertension. So that is all I have for you on that. Any other questions? All right. Well, let me know if y'all need anything and have a great rest of your afternoon.
Thank you, Dr. Staples.
Yep, no problem. Bye, guys.